And now I would like to welcome to the stage Dr. Mandy Cohen, the head of the CDC.
Thank you so much. Of course.
Have a brief chat here before we bring some more colleagues onto the stage. I'm very excited to launch into this conversation with you and hear about your work and your priorities for the CDC. You're recently taking on this new role, and I think this is a real opportunity to take, the skills, the resources of the CDC and really drive them forward. And I'm curious, when you're thinking about system strengthening, what your priorities are as they pertain to diagnostics.
Yeah. Well, first, great to be with everyone. Now we're getting late into the day, so thank you for still being here, and I'm probably keeping you from dinner. But I appreciate that Roche and Foreign Policy invited me here today, and I know everything at UNGA is always last minute, and I think I was last minute, so thank you for fitting me in. So just a second on my background. So a physician by training, but spend most of my time either in the federal government or at the state level. I was the Secretary of Health and Human Services in North Carolina leading through the pandemic. Lots of lessons learned there. But I want to start on a hopeful note, right? I also saw through these last number of years what we can achieve when we all have a shared mission, shared goal. And particularly when we think about diagnostics, it's amazing that in my purse right now in the green room, I have a rapid COVID test. And today you probably heard that the Biden administration relaunched a program to make sure that we are getting rapid tests to everyone across the country for free. So if you want to go order some more free tests, we want folks to have them because we think they're powerful, right? It's powerful. So the question is, when we were able to put our shoulder behind that, and now we can have everyone having rapid diagnostics in their pocket, how do we do that for other things, right? What's next? Where do we go from here? Where's my rapid flu test? Where's my rapid RSV test? And where's my combo that's gonna tell me, well, I just feel a little ill, what is it really? Like that's the exciting part that I hope we get to next. And when we talk about how we are making sure that we're getting to an equitable place of protecting this world, I think that's the next step, right? Is how do we get that rapid diagnostic to the most local level we possibly can. So that's what I'm excited about. Now, we have a bunch of ways in which we can do a lot better in terms of lessons learned. There were a lot of great things that happen, but I also think that fragmentation and silos really hindered our abilities. And I think you've been hearing that theme come up over and over again, right? How we could have been better and faster and saved even more lives if we were more integrated, whether it was integrating the public health and that rapid response into primary care and breaking down those silos, or the fact that we are so disease siloed, right, in the work that we are doing. I see that at CDC. So when you say, what are your priorities? One of them is to become one CDC team. And I don't want to see our TB team sitting apart from our COVID team, sitting apart from our HIV team. We're all helping the same communities. And so how are we both sharing data, sharing lessons learned, and building trust with those communities across disease states?
Absolutely. And breaking down silos, not even within the agency, but also across sectors.
Absolutely.
Right? So I'm curious about your perspective on that. How do you break down the silos, building on what we were just talking about in terms of partnerships between government and industry and civil society to ensure greater alignment and collaboration to achieve the objectives that you were just describing?
Yeah, I think that us moving through COVID, and I'll say leading that in North Carolina, we could not have done that without partnerships. I was very lucky to have LabCorp based in North Carolina, hugely important partnership. I had great relationships with our major hospital systems, hugely important to our response effort. We had Honeywell based in North Carolina, really important from a supply chain perspective, right? We harnessed all of those things and tried to put them together in coordination. So we can't be successful without those partnerships. And I want the CDC and sort of this next chapter of public health to be about breaking down those silos and integrating all the best parts of what we just talked about, health delivery, private sector innovation, and then the public health infrastructure that we have together, that takes us to the next future. But we have a lot of work to get there.
Yeah, thank you for that. And I think one way that we can all learn too is, homing in on the case studies, what's working, who is in the field, and different examples of that. And so I'd like to broaden our conversation and invite some colleagues to the stage with us now. I'd like to invite Isabel Mestres, the CEO of Cancer City Challenge, and Dr. Alex Costa, Senior Health Advisor of the Global Health Program Group at UNICEF. We can scoot down this way.
Do you want me to move down? Hi.
Thank you for joining us. We'd really love to dive into some programmatic brass tacks, if you don't mind, and learn from your experience on the ground, on the programs that you're working on, and learn more about what's working, and also how we can learn from that and work more collaboratively together for health systems strengthening. And so, Isabel, I'd like to turn to you first. I know you've been doing work in Ghana, and would love to hear a little bit more about the programs and the ways in which diagnostics have been absolutely vital to healthcare systems strengthening there, and what can be learned and brought to the fore as part of this conversation, and also the dialogue at the high-level meetings.
Thank you. First of all, thank you very much for Foreign Policy and Roche to invite me to be able to share. I am the CEO of City Cancer Challenge Foundation. We are a Geneva-based foundation, but actually we are a totally locally led organization. We work currently in 14 cities. One of them is Kumasi in Ghana. And basically we use cities as an ecosystem of action that can really mirror the full health system in a manageable scale. So instead of trying to address the whole health system from a national perspective, we go down where actually the data is and where the action is happening. So we're transforming all that policy or wishes into real action, and it's the local people that are driving change. So I am here as CEO, but I have to say that I wish the people from Kumasi and somebody was here actually, because this is a project led by them, and that's how the story should be. But being said that, of course, for cancer, diagnostic means life-saving. We're talking about it not only provides a diagnostic, but it's also treatment planning and surveillance. So what happened in Kumasi, through the data, through a full needs assessment, the local stakeholders identify as diagnostics as a huge gap. The main hospitals that treat cancer are overloaded, the labs. So the time is just unbearable for any patient. It's unbearable from a human being perspective to wait those long to hear what is your diagnostics. And there's also a lot of shortage of essential supplies. But around the corner, there are labs underutilized. And that's what the beauty of the city, that you can address from a systemic perspective, but across the city, and actually you can start connecting all the labs. And then through the connection of the labs, you can maximize resources. You can ensure that the quality of the labs are all at the same level by putting them all in a network, and you can reduce time. And time for cancer care means outcomes for patients.
In addressing this question of access and also inequity, I'd like to turn to you, Dr. Costa. You've been working on the advocacy toolkit, and I'd like for you to explain a little bit more about the work that you're doing, its utility, and how it can apply to local communities, but also be used elsewhere to really identify and deploy diagnostics, particularly in low and middle income countries.
Well, first of all, thanks for the invitation. So let me take a step back and talk about some of the lessons that we learned from COVID that actually led to the development of the toolkit. One of the lessons was, it was quite incredible to see how fast we could develop these technologies. Once our objectives converged, once there was political will and there's funding in order to develop diagnostics and vaccines and treatments at record speed. But the other lesson was that that was necessary but wasn't sufficient. So we could develop the technologies, we could facilitate procurement, we could shape the markets, we could strengthen the supply chains, but at the end of the day, the adoption of the technology, it depends on people. It depends on whether decision makers will prioritize diagnostics in their annual planning or their response budgets. It depends on healthcare workers, whether they know how to use the technology and interpret the results. And it depends on the beneficiaries and the communities, whether they understand the value of testing and whether they're going to use it or not. So what we tried to do with the toolkit was to identify some of these barriers and develop messaging around it. There's another element that I think is important to consider that's part of the toolkit in the response or the lessons that we have learned about from the pandemic. It's how centralized systems, laboratory-based urban systems were not enough to deliver to all of those in need. So laboratories are essential as a scaffolding, but in order to reach everybody, you have to decentralize service provision. We have to decentralize testing with a platform of health systems that's strong enough to do it, but also with rapid tests like point of care and near point of care technologies that will reach those people. So what we did with the toolkit was to carry out psychosocial research in representative countries in sub-Saharan Africa and in Southeast Asia, and mapped out 26 key barriers for access to diagnostics. Those barriers were then translated into about 50 messages that we tested in different settings and online as well. And then they were packaged in 166 assets, which actually blew my mind when I saw the results. These are static posts and animated GIFs, animations that dive into specific barriers. We have PowerPoint presentations that are modular and can be adapted to different audiences. And we have the community element, which is games and role-playing. And essentially what we're trying to do, what we did in the process of mapping was to target two audiences that we identify as key, because you cannot reach everybody at the same time. One of them was decision makers. It doesn't really matter if the technology is available, but the decision makers are not prioritizing diagnostics as part of their plans and their budgets. What happens is that there's a bottleneck at the very top, even if the healthcare workers understand the value of testing. So we decided to address that with advocacy towards targeting decision makers. And then on the other extreme was the communities, the beneficiaries of the service, who need to understand the value of testing in order to demand that. But because this is a social behavioral change approach, not advocacy, we basically created an adaptable tool that relies on advocacy champions, so civil society organizations, community-led organizations, faith-based organizations that work with communities in order to create messages that they can use very quickly, one size fits all, but obviously social behavior change is not one size fits all. So there are also adaptable tools that you can translate to your native language, that you can modify based on the needs and your understanding, and we sort of provide basic guidelines on how to adapt them to your local setting.
Where are you seeing the greatest uptake so far? I'm curious where it's getting traction.
Yeah, it's still, we launched this during the World Health Assembly at a side event. And I can't tell you where because we're not collecting that information yet. I know that Brazil, for example, is adapting the tool. And what we would like to do is actually document the adaptation of the tool. I think part of what we're trying to achieve here is that it's very clear that we need to do much more advocacy as a community. And repetition is essential. The more you repeat the messages, the more people understand it. So what we're trying to create is a resource, a global resource that's available for anyone to use that would allow us over time to create an echo chamber. And you can choose the messages that are relevant for your setting, or you can adapt them. But at the end of the day, if we actually use this as a community, we're more likely to succeed in our objective to raise awareness and increase access to testing.
Yeah, it's fascinating, and would love to know more as it progresses and how it is tracking, where it's gaining traction, and the differences, perhaps, in some countries versus others, some communities versus others. And I think it leads and speaks to this issue of trust, right? And reaching communities where they're at and patients where they're at. And so, Dr. Cohen, I'd like to turn back to you. When you think about those issues of trust and communication, and as an organization, how are you thinking about that and some of the actions that can be taken going forward to really build that trust and understanding within the community about the importance of diagnostics, the reliability of them? What are you focused on?
Well, I think we have to acknowledge that there's been a loss and an erosion of trust. And it's not just the CDC, it's not just government, it's media and science and institutions, and that's worrisome. But I do think that there is a tactical plan by which you can build trust back. And that's what we're trying to do from the CDC side of things. And, you know, I think trust is absolutely foundational. I've been saying a few times at the conference, change happens at the pace of trust. So if we want change to happen, we have to have trust come alongside that. But trust, I think, is built in three ways. We focused on this, again, I'm sorry to go back to my North Carolina example, but this is where we measured trust throughout the pandemic, and we actually increased trust in my department through the pandemic, which is pretty unusual, right, when I just said we had an erosion. Transparency, incredibly important. When people don't understand what's happening or feel like you're hiding something, they need transparency to understand the why behind what you're doing. You need to also execute well. You have to make things simple. So it's great to communicate, and I'm a huge believer, and I'm going to talk to you after about how we in the CDC can partner with this tool. But you also have to make it easy for folks, right? If you do all the communicating and then it is hard to get to, or it is hard to use, or it's expensive, or whatever, how many barriers, it's not going to work. So you have to make the execution simple and easy for folks, and that builds trust when they're like, oh, that was okay, that worked out for me. And then it's relationships. Like, we're all just humans. We're all just humans at the end of the day. And unfortunately, I see us in public health showing up when we want something. We want you to get tested. We want you to get vaccinated. We want you to do. Now, it's all in service of wanting them to be healthy. So it's all for good reasons, but we're showing up and wanting something. We have to show up and show up all the time, right? It's those sustained relationships. And actually, I think that is why CDC has been successful around the globe. They've been working deeply in communities for years. This isn't newly showing up, right? And so, but we have to be able to sustain that over time, and showing up and working shoulder to shoulder and side by side, and showing folks how that work feeds back to value to their community.
Mm-hmm. Absolutely. And Isabel, I'd like to turn to you to reflect on that. And in your experience, you know, how is trust being engendered and those relationships deepened so that there's more collaboration, there's trust on the ground, there's a recognition of the need for diagnostics? How is that showing up in your work?
Yeah, that's it's redundant, but it's critical trust. And in our case, one of the more, like for me, that I love about the model is that we work at city level, but we work in a multi-government layer approach. So while we work in the city, which is where action is happening, we work with the national government, we work with the regional government, and the local government. So building the trust between the layers of government, which probably are different parties, we think are one of the only initiatives that they come together to work. And that also helps a lot in the advocacy, because basically by the government, the national government being part of our project in Kumasi, they're seeing the results. They're seeing the evidence on reduction of time from diagnostics. So then most of the things that we're doing in Kumasi is becoming national. And then we're able to change national policy because we are bringing the evidence, and they're part of that. Of course, then the ecosystem, there's public and private institutions. What brings the glue together, it's our role. That's the value that we bring City Cancer Challenge, is that we bring them, we're a neutral party, that we bring them all together, and it's a systemic approach across the city. So what the trust comes with data. Once you have the data on the table, who's going to argue the data? So that's what we do a lot of effort. We work with, we have a very robust tool, was developed in partnership with NCI, with the support of Roche, to actually, it's around 1,100 data points across the system. So we assess all clinical services, pathology, blood bank, surgery, also the management of the services, human resources available, budgets, funding, digital. We assess the quality, and we assess the access. That data provides an incredible situation analysis report. I think the country doesn't have that information, but they're having for a city. And that helps stakeholders to come together. When we say we, We are 350 healthcare workers in the ground. SICAN is very small. We are a team of 40 global. We're operating in 14 countries, but in each country there's around 250 people working and driving change. We're just bringing them together. And not only we're addressing pathology, we're addressing everything. We're addressing the full health system. So in this specific project, there is 22 labs, both public and private, working together. And there's like a governance structure. There's a representative of each lab that is overseeing every day the lab activities. And there's also the local authorities, the Ashanti region, which is the supervisor body, and the government. And we want the government to be present because they're going to be seeing the results. And the results are starting to come there. The other thing is that we bring local companies. That brings a lot of trust. We try to avoid as much as possible other companies outside the country. So for example, it's a local company from Ghana that is deploying the digital tool. Local company is driving the courier to move efficiently the samples across the labs. And the results are there. Reduction of time of the results, which is incredibly important for the patient. But the most important is a reduction from suspicion to a final diagnostic. And that's life.
And those impacts on the ground and documenting those and being able to collate and share and report that data, I think will be incredible for informing policies, implementation programs at a higher level and at a greater scale. And so I'd love to hear from each one of you, and we're about out of time. When you think about localization, and I know that has become a buzzword in a lot of respects, but you've all talked about the need to really work with local communities and understand the needs, and how can that ladder up to what is now being discussed here at the UN General Assembly and amid the high-level meetings. You know, how can those lessons be taken, and what needs to happen this week? What actions can be taken, decisions be made to really catalyze movement in the interest of diagnostics and in the communities that you're working in? What do you want to see happen?
You can start. Well, I really appreciate this question personally. I think what I would like to see is that the international community, the people around UNGA, the development agencies, the international donors, what I would ask is one thing: patience. We are expecting change really quickly. And change, specifically in cancer, is complex. Change is not going to happen from one day to another one. And the pressure of change by the donors is making that we're not building the capacity of the people in the ground that should be the ones driving change. So what we have to do is build the local capacity. We need to train them on leadership skills, project management skills, M&E, health financing, implementation science, to make sure that whatever they do can be scaled up. But this pressure on time is making us all hire consultants to report quickly back to the donors, and that's not sustainable. We're going to report that this lab is done. But is it done for the long term, or is it done just to check the box of the donor? So I really want the community to be much more patient and bring the power to the people.
Thank you for that. Dr. Costa, what would you say?
So I would approach it from a similar angle, the community, but a different community. I think the role of communities on the ground should not be underestimated. In the international development sector, we usually, well, up until recently, we had a quite arrogant position of thinking of the solutions for them, when in fact we should be working with them. There's a lot communities can contribute in order to define your project scope, give your feedback of what works, what doesn't work, and really build a level of trust, again, that would allow your interventions to be sustainable over time. So I think we have to work more closely with the communities and make them part of the process, not something that we work for.
Very well put. And Dr. Cohen?
Well, I'll go back to where we started, which is I think fundamentally we have to be breaking down the silos that we're seeing, whether those are disease silos, whether those are country silos, whether that is government versus academia versus private sector silos. I think there's lots of good work happening, but it's in pockets, it's in isolation. We aren't sharing and transparent. We're tripping over ourselves. Everyone wants to do good work, but I think there just needs to be some much more proactive sharing of information, which feels scary. Everyone either wants to get back to their donors or publish a paper or claim the victory. But I think if we're actually going to make progress in a coordinated way, that we have to have some semblance of breaking down silos and using certain platforms for more than one thing. So if we built something great for TB or HIV, let's use it for respiratory illnesses, or and as opposed to like building something new each time we have something. So I just think there's a lot more we can do to be thoughtful about our priorities, linking together and knitting together these silos. And look, and I look internally first, right? We have to walk the walk. CDC has to do that better, and we are committing to do that. But I see that as a parallel for what needs to happen across the board.
Thank you. Very well put. And thanks to all of you for your work and for joining us tonight. We appreciate it.
Thank you.
Thank you. Thank you.
Please welcome back to the stage FP's Andrew Solinger.
So that will, originally I was going to do a talk with Baroness Scotland. Unfortunately, she had to run. She has actually been here all evening, but she had to bolt a little while ago. So we're going to cut us all a break because I've done a diagnostic on everyone in the room while we're all sitting here, and you're all thirsty, as it turns out. So I wanted to really just thank you, though, for sitting through this really interesting and fascinating program. I was very impressed. I learned a tremendous amount from across the world. There's some innovative things happening, and it's really a reason for hope. I also want to thank Roche for partnering with us on this event. It was really fantastic, a great way to end a wonderful day. So thank you all for coming. Please join us for some refreshments and networking. And come back tomorrow. We have some great programs, not on diagnostics, but on technology in the morning and energy in the afternoon. Thanks so much.